Good evening, everyone. Thank you very much for taking the time to join us tonight. For those of you that don't know me, my name is Tim Pecker. I'm the superintendent, and in a few minutes, I'm going to introduce our special guest. But before I do that, I do want to definitely take a moment to thank our parents for the support that they have shown our teachers, our staff, and our school district throughout the entire school year. This has been a challenging year. We've navigated it the best that we can, and your patience and support is greatly appreciated. All the decisions we've made over the past year have been try to balance the health and safety needs of our students and staff with the learning and social emotional needs of our students. As you know, we started the year in 100% virtual format, like every other school district in St. Louis County, based on the recommendation of the health department. We were actually one of the first districts in the county to resume some form of in-person learning in September. We've stayed in the blended model. We've been consistent in that, and it's worked really well. Last week, I sent an update, and hopefully you had a chance to read that, and a couple takeaways from the update on kind of where we're currently at and what does the second semester look like. One thing, and this is important to know, it's our hope to begin to transition to more in-person learning. And in the communication I shared to look for some updated communication in February, probably by the middle of February, with some specific details on what that might entail and for which age groups. Tonight, we're going to have a chance to hear from Dr. Jason Nolan. He's going to talk about school transmission rates, the CDC project that Pattonville has been a part of. He's going to talk about the vaccine. As he's going through his presentation, if you have questions, there's please ask them through the Q&A on the bottom of your screen. And at the end of his presentation, we'll try to get as many of those answered as we can before we end at 7 o'clock. One thing I do want to remind you, once the webinar ends, please stay connected for about a minute afterwards. You're going to get a short survey. We're going to try to get some feedback on the presentation, as well as some information on how we've done as the school district on communication during the pandemic. At this time, I do want to introduce Dr. Jason Nolan. He is a professor of pediatrics at Washington University and a physician at St. Louis Children's Hospital. He leads the BJC Healthcare Systems Infectious Diseases Clinical Expert Council, and he served as the Pattonville liaison during the CDC study. I've had a chance to get to know Dr. Newland. He's a wonderful individual, very engaging. So I know tonight's presentation is going to be great. So again, I want to thank you very much for tuning in. And at this point, I'm going to turn it over to Dr. Newland.
Thanks, Tim. Thank you so much to you, to your staff, to your teachers, to your families. Pattonville has a special place in my heart, always will. As Tim will tell you, I'm going to write a song about McKelvey Road with all kinds of things, but we will talk about that later. I really am excited to share with you some of my thoughts, experiences, as well as the data. And I'm hoping to inform you all to provide some important information as we move forward and we move through the end of this pandemic, and because there will be an end. And you guys have demonstrated how to do this and continue to educate your students and keeping people safe, which is so important. You should know just a little bit about me. I moved to St. Louis in 2016. My first day was January 4th, 2016. So I've been here 5 years after spending 10 years in Kansas City. I have 3 kids. My oldest is a freshman at the University of Arkansas. So obviously the pandemic had some pretty big impact on him. He's up here in this upper right corner. And then probably my favorite pictures of my youngest daughter, who's a freshman at Kirkwood High School. She got this picture in the St. Louis Post-Dispatch. And I love it because it just reflects the pandemic in so many ways and so many things that I think our communities have been trying to do to make sure kids can still do things. I love, obviously, the mask and the cheerleaders. I cropped out the opposing team because you couldn't quite see it, but they were masked. So I think it shows how people have been innovative, and you all have continued to support and make this work. So I'm going to talk about a few things, and I'd like to just start, let's level set things. I mean, you probably heard all kinds of different names, and I want to talk also about the variants, this newfound word that we talk a lot about. But so first, what's the virus? The virus name is severe acute respiratory syndrome coronavirus 2, or SARS-CoV-2. You should know that SARS-CoV-2 has these cousins that were really more severe called just regular SARS that emerged in 2002. And then there was something called MERS-CoV, or Middle Eastern Respiratory Syndrome virus, that emerged in 2012, 2013 on the Arabian Peninsula. It's important for you to know that. And why would I say that? Well, because those severe illnesses have really driven a lot of the research that allows us to be able to offer a vaccine already, because we already learned a lot from those viruses on what would be needed for an immunization or a vaccine to help protect us. Now, the next thing is, what's the disease called, right? We all refer to it as COVID-19, and I likely will refer to it COVID-19 throughout, but that when you get infectious and you have the infection and you're sick, we call that coronavirus infectious disease 2019, or COVID-19. And that reason for that is because the WHO, or World Health Organization, was first notified of this virus and actually December 31st, 2019. Now, I want to talk about the variants, right? So, I mean, many of you out there are like, I keep hearing about the variants. What in the heck is this variant? Well, here's the thing. Viruses need other things or cells or other living things to make more of themselves. It's like a parasite in many ways, but think about your cell being a place that the virus goes to then make more of itself. Well, when you are one of these viruses and you're making a lot of your cells a lot, right? That's your whole job, is to go in, find a cell, and then make more of your cells. You have all this genetic code, and well, you're just going to mess up that genetic code sometimes. And that's what leads to mutations, that leads to different mutations within the original strain that gives you these variants. Now, as we've learned in evolution, right, that things evolve or mutate to help make itself survive more. And so what we found is that as this virus has mutated, it's found some ways to have populations or variants that are more present than other variants, because sometimes you can have mutations that are harmful to the virus. So this is not unexpected. Virologists, people that just spend their whole lives worried about viruses, that's what they do. They know that these variants are going to happen. Influenza makes variants all the time, and then we have to try to predict which variant is going to be the one to vaccinate against. Now, there are 3 big variants, if you go to the CDC website, that you likely have heard about, that they're paying attention to and following. So the big one that we've learned about first was this United Kingdom B.1.1.7, which really refers to some of the positions of the mutations. It is thought to be, and more of the experts that you read will say it's probably more transmissible, meaning it can get more infectious, though maybe from a 10% to 15%. But the impact on disease severity is not severe. Now, this variant has been seen in the US. It hasn't been reported that I've seen in Missouri, but people are worried. And that's why we're seeing more of these travel restrictions when someone's coming internationally into our country. There's the South African variant, again, that they're saying no impact on severity of disease. And as of what I could find today, not identified in the United States. But as you all know, the things are ever changing, and I could be speaking wrongly just because something came out an hour ago. Then lastly, there's the Brazil. The Brazil one has been found in Amazonas, where they had a huge outbreak early in October. Right at the beginning of the pandemic. And the thinking was maybe this community had herd immunity, but now we're seeing this again in Brazil, this variant with some possibly increase in transmissibility. My horrible pop-ups. Sorry. There's been one case found in Minnesota. And I think the most important thing with this is that the vaccines that we have are still effective against these variants. If you look at these things and the antibodies, that the vaccines are still effective. In the Brazil case, it's not as effective, but we're talking from 95% to maybe 75%. And in context, our influenza vaccine is usually around 60 to 70%. And many of us were hoping just to get 70% vaccine efficacy with our vaccines. Now, I want to step back, right? So we have this virus that's going back. Well, what's been happening in our community? So this is where people that are in epidemiology or in infectious diseases like myself, we look at this curve, and this is like we focus on a lot. And so what am I showing you? Well, you have these green bars, which we populate each day. And that's the new number of cases. And this is in the St. Louis metropolitan area. Additionally, you'll see that there's this blue line. That blue line is taking a rolling 7-day average. So on no, on January 25th, it looks back the 7 days, including January 25th backwards, and says, okay, that point is my average. And you see this blue curve, right? We see, right, as it started to rise around the time of Halloween, and then we peaked kind of right before Thanksgiving. Then we saw kind of what I call the Thanksgiving bump around December 1st. And then we've seen again, I would call the New Year's Eve, Christmas bump and the beginning of January. And now we're kind of slowly coming down. And the real smart mathematic people are suggesting that modeling data, looking at what's happening over time, maybe we'll get down to July levels by the summer. And maybe that'll get better as we get more and more people vaccinated. Now, I show you this picture of all this spaghetti, and you're like, man, Jason, what are you showing me? So what I'm trying to show you is to look at the different counties within our region. And on that y-axis, you will see the number of cases per 100,000. That's just a common number we use. And obviously, the higher it is, the worse it is. And you can see, and the point of this is that the younger age group, so the 0 to 4 is for almost always the lowest group. In each age group, as you go up, is just a little higher, a little higher. Now, the 15 to 19-year-olds often can be like with the 20 to 24-year-olds, but the most important thing is that usually the kids have the least amount of disease, which is a lot of times unlike our influenza virus where we see kids drive influenza. Now, you all should know we're not seeing influenza. Our hospital hasn't really had an influenza case admitted in a while, if at all this year, which is highly unusual. And so the things that are being done, the masking, the distancing, people staying home when they're sick, these things work. And they're working for other viruses. And as you can see, they are working for COVID-19. Now, as we move forward, I want to go into this school conversation, we got to understand how this virus is transmitted. And you guys know this. You've been living this. We're almost been living this for a year, which is mind-blowing for me many times. So how does this virus get transmitted? Well, as you guys know, it's mainly respiratory. Now, early in the pandemic, we were wiping things down, washing our hands a lot, and we should continue to do that. But the main way is respiratory. And it's usually the main way is droplets, meaning it kind of goes about, well, say 6 feet, though I'm not, we'll have to see how that is really, but we know that getting beyond 6 feet for the most part will protect you. Now, there are instances where we've heard about aerosolization, meaning that these virus particles are up in the air, floating around. And in those situations, those have been primarily in congregate settings where there's a lot of people and there's no strategies to prevent transmission, like masks. Those things, masking really helps. And so I think that's the thing to realize is that transmission is primarily person to person. And also it can be a gathering disease when there's not what I call the mitigation strategies or the prevention strategies in place. So school's not a place for this, right? Because Pattonville schools, which we've been working with now since December or in November, all those strategies are in place. And we are seeing more and more of the data, and the data that the school has and has shown is like, transmission is really, really rare. And that's what we're seeing across the country. So what are those strategies? You know them. You get screened and we make sure people aren't showing up to work or school when they're ill. We wear our masks. I think I was on a call with someone today and we were talking about, we really underestimated our kids and their ability to wear masks. I mean, I'll be the first to say in June, one might say I was arguing with a colleague up in Chicago. He's like, we should just mask everybody down to, 5 and just do it. And they can do it. And our teenagers are doing it when they're in school, they're doing it. And when we ask them to do these things, the culture's there. Obviously distancing, more is the better. But I think what data has shown with some other studies that greater than 3 feet with mask has been effective. And we're working on that to continue to show that. Obviously hand hygiene, wiping down high touch surfaces. And I really believe vaccination obviously is another strategy, and that's coming soon to the educators and eventually will be to the students. And I will talk a little bit about vaccines to give you guys some information to help you in making that decision to go on to get vaccinated. All right, so now let's talk about the data about how schools are so important and how in-person school is actually great for our children's health, not only for the social, emotional education aspects of it, but additionally for actually protection against COVID-19. So what you're seeing here is, right, we have this group of kids on the left in that pictorial, no mask, hanging out, doing things. And we have the kids in school with masks and some distance. And we had a group of pediatricians across the community. You know, the pediatricians and the nurse practitioners that care for your children are amazing. And they spent from July until about middle of October having kids who came in with these COVID-19 like symptoms, you know, like runny nose, cough that could look like any cold. And they just basically said, okay, here are your symptoms. Here were your exposures. Were you in school or daycare? Where else were you in your house? Those sorts of things. And then if your tests were positive. So they actually collected data on over 2,000 children. It's an amazing effort by these individuals. And we had about 200 positives. And lo and behold, when we looked at the data, it said that being in school or being at a daycare was protective, meaning that was protected than if you weren't. And I was like, wow, that is really, I mean, that's amazing. And I think when we first saw the data, we're like, well, I want to say, look, I'm not sure, we need to keep looking at this data. Let's make sure we understand this. But I felt very confident to say, look, there's no doubt school is not harm. It's not increasing your risk. It's a good place to be. And if we know that the benefits there, all the benefits are there, then I think that's a good thing. And we should be thinking about how do we have more in-person school. And mind you, think about that timing, right? I told you it was August, September into October where we had significant rates of disease, not like what we had in November, December, and what we're coming through right now, but it still was significant disease where some data would suggest, why would you even have in-person school? Or I should say some expert recommendations is why would you have in-person school? And so I think the fact that you all were leaders and doing this and showing how it was being done, it was good for our students and our staff. So then this paper came out. This paper actually was published in what we call the Morbidity and Mortality Weekly Report, which is the CDC journal. It is like kind of, for a lot of us, like, wow, that's the journal to look to, especially in the pandemic because of what they do. And what they found, this pictorial is awesome. It says compared with children who tested negative that caused COVID-19, children who tested positive were more likely to have attended gatherings, weddings, parties, play dates, funerals, not more likely, meaning it was actually protected to be in school, attended childcare and school in person with masks. As you can see in the pictorial, everyone has a mask on. And in talking with the lead author, a wonderful colleague down in Mississippi named Charlotte Hobbs, she's like, look, we made it a point to make sure that we had masks in that picture because that matters. And so I want you all to know, like these things being put in place are super important. And that's why we've been able to show the safety of school. Now, a new paper came out just recently in the past 2 weeks from North Carolina. This is data from their first 9 weeks of instruction where they were in this hybrid model where they did kind of that 2 days in for one group, 2 days in for the other group, that middle virtual day. And I know that you all have a hybrid model currently. And they looked at 90,000 students and staff involved with in-person instruction. And they found that their rates in the community were much, much higher. So 773 community-acquired cases, only 32 cases due to in-school transmission. And transmission was rare if it adhered to the mitigation strategies. It is super important to understand because people say, well, maybe they didn't have much community disease, and that's not true. Their rates were much higher, or, they were definitely higher than what we've seen in St. Louis County during the time we've been in school. So those rates being 100 to 200 per 100,000. So then just 2 days ago, or actually just yesterday, my email started going off and people texting me this study that comes out of Wisconsin. So this is K through 12 schools that had in-person learning and have shown limited in-school COVID-19 spread. Now, it seems clear to me, or I should say, it seems that these were 5 days a week, though I'm trying to confirm that because it wasn't clear in the paper. But you can see they found that 92% of their students were wearing masks. Now, how did they determine that? It was actually the teachers. It was the staff who determined who would fill out weekly what their percentage of mask compliance was. They established groups. The staff, and this is where I think they probably had some students probably within the 3 to 6 feet, but the staff maintained 6 feet of distance if possible, and they did quarantining. And during that 13 weeks of in-person learning, 7 of their 4,800 students became positive and none of their staff. There was no staff, there was no student to staff transmission in this. So I think this is really important. And they also talked about how that their community rates of disease were much, much higher, almost I think double than what their school rates of disease were. Their positivity rate in the school was like 3%, while in the community range from 7 to 18% or 7 to 19% during this time. So this is super important. This is really important work going forward to say, look, this is more data showing that our in-person school environments with the prevention / mitigation strategy in place is a safe place for our students and staff. So this is just anecdotal data that we received from Missouri Department of Health, where a number of superintendents across the state had grabbed their positive cases, the number of people that were quarantined, and found that among those, 126 were positive, or 0.7%. Many schools reported no positive quarantine staff. Now, you can poke holes in this, right? It's anecdote, it's people reporting. You can talk about the biases, but I think as we get more and more data, let's just say there's some error in this. Even if they were off by 1 or 2%, you're still talking about low rates. So this moves in to kind of what we decided to do. We've been really, I call it blessed, to be able to work with our St. Louis County Health Department, the Springfield Green Health Department, where I am with Washington University, St. Louis University, and the CDC. So we reached out, my colleague Rachel Orslin, who hopefully many of you have heard, who's just a major stalwart leader in the getting kids and staff back at school safely. We put a project forward to the CDC back in October, really trying to understand this transmission. And they've been working diligently with us to the point where we actually did a pilot. And, working with Tim and Matt Goodman and others, it became clear to me that Pattonville would be a great place to potentially do this. And so I reached out, and, Tim and his staff, just like open arms, says, our community would love to be a part of this. And your community, like, I can't say thank you enough. I mean, this has been, this will always be a silver lining for me. If Pattonville ever asks me to do something, I will do it, and I'll run through a wall to do it for you all because of the support, and just how wonderful everyone has been to welcome us in doing this work. And so I want to describe that to you, because your community deserves this, because you are helping students across the country. Now, it's not just the state, but across the country. I mean, I was on the phone with the New York Times today and others, and we know this has some great implications going forward. So what was the purpose? Well, our goal is to find the best ways to keep children safe and in school, and really it's to keep children and staff safe and in school. We really believe that we want to make sure that the teachers have that safety, the kids have that safety, and that you all can provide the amazing things that you do every day to these kids. So the objective was to examine the impact. And how do we do that? We basically have our community and we have our school, and there's a lot of overlap. And we know that there's households, and we know there's a lot of transmission in the households. We also know that in school, there's many different things, right? There's lunch, there's recess, there's extracurricular activities, there's the classroom, all these places where transmission could occur. And then there's these non-school associated activities in the middle. If you look at the community and we says how much transmission, what we're looking at really is this: how much transmission, just focusing on the school, but really doing intense investigation to make sure that we're not attributing potentially community exposures. And so we are really measuring how our mitigation measures affecting transmission in schools, and we're looking at quarantine policies. We're looking at things within the school. We're working with the school. And so in December, we started our pilot investigation with the Pattonville School District and 2 private schools in St. Louis. And we wanted to evaluate mitigation strategies as well as the Springfield modified quarantine policy. So for many of you who are like, well, what is modified quarantine? Well, modified quarantine was announced by the governor on November 12th that says local counties could decide to use a modified quarantine policy, which means that if you had masked cases, so people that were infectious in school and their contacts were also masked, then they could remain in school, that they would not have to be quarantined. And so we knew that St. Louis County has remained to say, well, if you have a contact because of our rates, we're going to still have the 14-day quarantine. And so we really wanted to look at this. And so we conduct this by doing enhanced interviews of the cases, as well as enhanced interviews of the contacts. And then we provide free testing for the cases so that we could have the virus as well as the contacts to see if we would have any positives. And then the CDC has been an amazing partner, and we sent some of the specimens to the CDC for sequencing, meaning we're going to look at their genetics to see if they're exactly alike, to say, okay, yeah, those are probably from the same, because like I said before, right, viruses like to mutate. All right, so we use this awesome saliva test that was developed at WashU that has FDA approval. It's really great. We've been collecting specimens at homes. I talk about McKelvey Road because if you get to drive around Pattonville School District, you land on McKelvey Road a lot. And you have the donut shop and you have this, and I think it's a perfect song. And so I'm going to work on that and hopefully sing it to you one day. Actually, I'll have somebody else sing it to you. But we've done this testing. I've been able to go to homes. We've gone to homes. Now we're setting up some central testing site, and we can get good turnaround time on this. So I've talked about that. So what were the results for you all? Well, the Pattonville results, we had 12 of 17 cases enrolled, and we only enrolled from kind of the 1st of December until winter break. So and actually it was December 7th and December 18th. And this was amazing. We actually got 48 contacts enrolled, got them tested. I mean, it was remarkable. It was so remarkable that CDC was like, wow, this has really worked. You guys have really shown that this can work. And while we have all of this great data, we want to come back. We think we can answer these questions even better. And so I should tell you that what we learned from just the pilot doing this in St. Louis and in Springfield was that there was rare transmission in school. There was no transmission in children in modified quarantine. There was no student to teacher transmission. And actually, literally, before I got on this call, the hope was that the pilot data would be published and I would be sharing all this data that we got with your guys' help. But I just got an email that potentially, I think it's really potential that we might see this publication come out next week. Now, Tim can tell you I've been wrong every time I've said when I think it's going to come out. So I'm scared to say that. But I think we're going to have some more data that's published, that's out there for the world to see. All right, what's the next step? So we actually started the project this week. I was on McKelvey Road today, picking up some specimens. We want to further evaluate our school transmission and better define distancing, quarantining. What about extracurricular activities? You saw, like, I love sports. I love drama. I love the extracurricular activities of school. How do we assess those to make sure we can continue to offer those in a safe way? And then also we're sequencing, right? So we can monitor for these variants and see how that impacts. And the plan is that we're going to do this probably until spring break. As we try to get the goal between here and Springfield is to get about 2,000 contacts. And so we got a lot of work ahead, but we have a number of people from CDC here. We got a great team with SLU, WashU, and others, you all. And we've added some other school districts to help bolster our numbers. And so we'll see. And I'll be the first to come to you all to provide you that data before it comes out and at least share with you our learning. All right, so with that, I'm going to move to vaccines. I just gave some talk last week. I really want your community to understand what's out there for vaccines. I want you to be thinking about this. I think this is our way out. We're going to still mask and do these things as we get vaccinated, but as we get vaccinated, we're going to see that that's the way to get back to what we knew prior to COVID-19 pandemic. Now, there are 9 approved vaccines around the world. The 2 approved in the United States are the Pfizer and Moderna vaccine that are based on an mRNA or messenger RNA-based vaccine. We'll talk about that. And then there are a number of vaccines in the developmental stages. And that is a good thing because that means we're just going to have better and better things as we go forward. So look, all guys like me probably should not show this figure to the right. And many of you are like, what is he doing to us? But this is like, I mean, you should know that I wanted to be a virologist. I worked in a lab. I thought it was amazing, but I just wasn't very good at it. And I'm much better at kind of talking and doing these sorts of things. And what this pictorial is just demonstrates the many years of research that has been done to get us to the point that we understand these viruses very well. We know exactly how this virus binds to one of our cells. Think about the binding of a cell as like you grabbing onto a door to get into a room, right? What a virus wants to do is get into a cell, so it grabs a door handle, walks into that room or walks into that cell, because inside the cell, it has all the things it needs to make more of itself, right? So that's what the virus wants to do. And we know that this virus binds to this receptor called the ACE2 receptor, and it uses what we call the spike protein. That has been taken many years, probably over 20 years of research to do this. So I think that's important. Technology and research has also allowed us to move to the point that once they identified this virus, they could get that genetic code or that sequence quickly, right? So mid-January last year, there was already a sequence out that knew exactly that this is the spike protein region. They already knew that the spike protein was the place where other coronaviruses like SARS-CoV-2, you could get that immune response, or where our bodies would make those things to protect us or to fight against that virus. So, man, we were already really in a good spot, but now we just had to get it into the technologies that have been developed so that we could have a vaccine. And so I think that's important. And I think it's important to understand that because there's not been shortcuts. I mean, this has been ongoing in many respects, and now we're prepared to just really execute it. And that's what was different, is that we knew and now we could execute quickly. Now, it should be known that the studies done to get to the point where I've already received my 2 vaccines. As a matter of fact, 2 weeks ago to this day was when I got my second dose of the vaccine. It feels really great to have 2 doses. But there was no shortcuts to get to the point that I could do that within a year of identifying the actual sequence of this virus. And why is that? Because they did the phase 1 studies early. I think they started doing those in April. Phase 1 is here. 20 to 100 healthy volunteers to say, is this vaccine even safe? What are the side effects? Are there any serious side effects? And what's the dose? Is it supposed to be 50 micrograms, 100 micrograms, 200 micrograms? You know, as you get more doses, you would expect maybe more side effects. And that's what they found. And they landed on the 100 micrograms for the Pfizer vaccine or the Moderna vaccine. They then go to these phase 2, and sometimes they'll combine the phase 2, phase 3. You can see the phase 2 is usually a several hundred volunteers. And those trials are looking at what's your immune response? Do you have these, what we call those antibodies? And then we get to the phase 3, and our phase 3 studies started, July, August. And it's super important for people to know is that the FDA basically said, look, you cannot approve this vaccine until we have 2 months after the second dose. Because in 2 months, we will definitely know about serious safety events that have occurred from giving the vaccine. And I think that's super important. People should know that. They waited. They knew they had to wait to see what was going to happen. And that's what they did. And I think that gives you the sense that all these steps were met. The facts are every step was met. We were set up to be quick. We were able to do that. And people just jumped on it. They were able to try. Now, the other thing that's important to know, the reason why the trial was able to end earlier, or one would be able to say it wasn't effective or not, is because we had such high rates of disease in our country. They hit their target number of infections really, really quick. The last thing you should know, in regards to how we monitor, all vaccines have what we call the post-marketing surveillance. Like there are people there's apps that people that gets vaccinated can enter in the data about their side effects. Those things are continually looked at and monitored as we move forward. All right, so this is really cool from a guy like me who's into science. Those of you guys out there in science, you just and like this stuff. Like they basically came up with this mRNA technology with nanoparticles, and they put this messenger. Think of messenger RNAs like it's the message that gets into my cell, and then my cell says, "Oh, I see that message. I should make the protein." That's what happens. So I get the message into my cell, I go to these ribosomes, and I make that spike protein, because that spike protein, we have learned, is how you get the immune response for protection. So that's what they did. They gave it the phase 3, started end of July, 30,000 subjects, 15,000 gets the placebo, 15,000 got the vaccine. And the efficacy was amazing, and I'll show you the data. It's 94, 95%. It was approved Moderna December 18th. Pfizer was approved December 11th. Pfizer had 44,000 subjects. You all know this. Moderna actually requires a regular freezer. Pfizer requires this ultra cold freezer, like minus 80 degrees centigrade. So, I mean, it's pretty cold working with them. You wear big old mittens and stuff as you work them, but that's how you have to store this vaccine. Now, here's this data. This is just a pictorial, right? That says, okay, look, with that Pfizer vaccine versus placebo, they had already set before they did the trial that they needed to get to 170. When they got to 170 people with COVID-19, they're gonna break open and see where those sick people were, and they found that 162 were in the placebo and only 8 or received the vaccine. And there was only 1 seriously ill, 9 seriously ill in the placebo. So suggesting not only did you have 94, 95% effectiveness, but also it looks like it prevents against more severe disease. Moderna also saw the same thing. Now it's important to know what are the side effects. So you can see there are a few side effects, right? So 73% experienced pain at the injection site. This is after the second dose. I can tell you, I experienced pain at the injection site after both doses. 56% will have fatigue, another, 47% headache. And I can tell you right now, I was doing fine, got my second shot on a Wednesday. Thursday at about 12:31, I was like, I just don't feel quite right. Thursday at about 5 p.m., I was asleep for a couple hours, kind of achy. Friday morning, I woke up, worked out, and felt just like normal. And that's been a common experience for a lot of people. And I've felt great ever since. And there's also some obviously emotional feeling great about it as well. And so that's why I want to get this vaccine out to all of you all as well. So here's this is really jumping into the clinical trial design. This is what they call a Kaplan-Meier curve. What you're looking at is these are the people with this is placebo in red. This is basically, as this goes up, that means those are all the people getting infected, and this is placebo. No one's getting infected in the placebo. This spread is what you're looking for. The scientists are looking for, or those epidemiologists, those in the clinical trial design. This is super important stuff. All right, so now I want to talk about 2 other vaccines. So many of you maybe have heard of the Astrazeneca vaccine. This is approved in the United Kingdom. This is a different mechanism. This is basically they use an adenovirus. And this is an adenovirus that can't get into your cells and make more of itself. And they basically deliver some DNA into your cells so that you can make some spike protein. Same way, right? It's similar to what the 2 approved vaccines are doing, but just getting it there differently, right? So that's just important. There's some differences. So there's the AstraZeneca vaccine that uses chimpanzee adenovirus. And then you have the Johnson & Johnson / Janssen vaccine that also uses one of these, what they call replication incompetent vectors, meaning it can't get in your cell and make more of itself. And again, all the same philosophy of let's get that spike protein into our bodies. So it's not the virus, it's just part of the virus to make more of so we can make antibodies. And the data has been very impressive, suggesting that the response you get to this vaccine is definitely better than response you get from actual getting infected with COVID-19. So the other thing about the Janssen vaccine, the second one, is it looks like you might only need 1 dose. Also, these vaccines only need a refrigerator. So there's a lot of benefits potentially. Janssen, if it's only 1 dose, will be amazing. AstraZeneca is still 2 doses. All right, so vaccine distribution. You probably know this. Currently, we're in the 1B in state of Missouri. 1A was healthcare workers, nursing home residents, nursing home employees. Now we're into this first responders and high-risk individuals. And then tier 3 will be critical infrastructure, including our teachers. Obviously, I want us to get to there quickly. I was hoping the teachers and our educators, the people that really make school work, the people that I will always be thankful for. I always say I apologize to you all for having to say it took a pandemic for me to even realize to the great benefit you teachers out there are to our kids. I've seen it firsthand. I've gone to schools now and watched you all care for kids during a real difficult time in amazing ways. So let's talk about future pediatric vaccine trials, because I think this is what's important. Students are going to have our students are going to have to be vaccinated. That's part of this, right? I mean, I think that'll help us get further on, and that's what we're going to be working on next. We know the Pfizer vaccine is approved down to 16 years of age. Pfizer has had some studies nationally looking at 12 to 15. Moderna is approved down to 18, and there's studies ongoing with us. We have been approached, we being Washington University, has been approached about performing the Moderna, Janssen, and Pfizer vaccines. We have been selected to be a Janssen site. The plan is, depending on all the things we have to go through, is hopefully we'll have those up and running by March. I'll definitely reach out to your community to let you guys know this. Obviously, always volunteer, but that's what's happening. And I'm hoping by the fall, the studies don't have to be as to the level that they have in the adult stuff, because we have a lot of information already. But my hope is by fall we'll have vaccine approved for kids, and we're talking about how do we get your students vaccinated next. So with that, I just want to thank you. I'd love to answer the questions and appreciate the time that you guys have given me tonight.
Dr. Newland, thank you very much. Great information. I'll just kind of read some of the questions to you that are directed to you.
Yeah.
First one is, lately I've seen a few stories about wearing 2 masks. Is that better?
Yeah, so I mean, Dr. Fauci came out right about, I learned about this from a wonderful colleague, a pediatrician who emails, hey, Jason, what do you think about Dr. Fauci talking about 2 masks? I said, well, here's what I think, right? I will say the data we have on, let's talk about schools in the setting of schools. The data we have has all been, let's have the kids in masks, let's have cloth masks, and they've all worked. Dr. Fauci will say, let's add, if we have, surgical and put over another cotton mask, maybe that adds a little more. The key has been is that we wear masks. And so if someone wants to wear a second mask, okay, but that, I think that, we need more on that if people, but I don't think we have to say, hey, everyone needs to wear 2 masks at this point in time. That's not where I think. So great question, important to see as we move forward. And I think I'll just give, this is what infectious disease people do, is we take one question, we turn it into 6. The other thing about that is people say, what about the variants? Well, look, the mask is going to work against a variant, right? The mask is basically a barrier. It's a physical barrier. A variant it's not like that variant has changed completely its structure that now it can kind of weave its way through the mask a different way. So that's still going to work. The mitigation strategies are still going to work. So.
All right, Dr. Newland. There was also a question related to the study when it is publicized, if we would be able to share that with everyone, and I'm sure we're going to be able to do that.
Oh my gosh, I will send it first to you.
Okay.
Yes, I can't wait to be able to say, hey, share this with your community, let everyone read it. We will love that. Absolutely.
There were a few questions that were kind of more directed, I think, from staff to me, and I'll just let you know, I'll get back with those individuals personally. A question about, when would Pattonville staff members be vaccinated? And as Dr. Newland kind of mentioned, that's still kind of a work in progress. I sent out a message to our staff a couple of days ago, kind of based on what we've heard from the health department right now, encouraging our staff to sign up with the health departments where they live. That's one avenue. We are definitely still hopeful at some point as a school district, we will be able to coordinate something for our staff.
Hey, Tim,
Dr.
I see.
Newland, there was one question,
Yeah.
Dr. Newland, you can help us with. There was a question about specifically on the 6 feet.
Yeah.
For us, obviously in the current stage we're in the hybrid model or the blended model, we're able to accommodate that in most settings. And you mentioned that a little bit on 3 feet or greater. Can you just talk a little bit more about that?
Yeah, the data has shown, at least in what we call a meta-analysis, which means they looked at a bunch of studies, and this was published in a well-respected journal called The Lancet, that showed that with 3 feet in masking, you got the same kind of thing if you just had 6 feet. So I think, the CDC and others still say, and I always say this, look, if you can do more, it's better. But I think if you're beyond 3 feet and you're doing these other things, that's going to provide the protection. Now, that's exactly why we're continuing to do our projects, right? I want to get more and more data on that. But I think that, I have a question out to this Wisconsin paper that just was published specifically to that question, because the way you read it suggests that they weren't all at 6 feet. I mean, that's how it reads, because it just talks about the staff being at 6 feet. And so I think that to me is probably further evidence that when we do this, that, I will look at it like, I think the benefit, if you have some just within that 6 feet or beyond 3 feet, and not having much, having rare to no transmission, that outweighs the risk for sure in my book.
Okay. Thank you for that. As we're kind of just scrolling through here and trying to see if we have any more questions, I do want a couple of reminders. One, we have recorded this, and we'll be making this available to our community in the next day or two. So look for something related to that.
I see a question on the vaccine, Tim, if you want me to
Yeah, go
answer
ahead. Yeah, go ahead.
So what is the cause of the side effects? So this is really, I love this question, Marion, for a lot of reasons, just because it gets into immunology, and while I'm not a card carrying immunologist, I think I love to think this. So, after my first vaccine, I just had a sore arm. I had nothing else. Now I know some people that have had some side effects with that more. But what we learned with the Pfizer and Moderna data was that the first dose gave you more of those antibodies. And then the second vaccine actually stimulated another part of your immune system and got more of your T helper cells that likely get you to have like more of what we call the cytokines to start responding. And I think you're feeling the cytokines, that they're kind of revved up after seeing this second dose. Some people who have been infected, and if you've been infected, we still recommend you get the vaccine. Some people who've been infected in the past 3 months and get vaccine have reactions potentially a little stronger earlier on, likely because they're getting that other part of the immune system response. The next one is about, do I think that school districts should require students get vaccinated? Obviously, there might be some religious exemptions, but should they be required in your opinion? Look, I mean, I don't think we'll ever be requiring the COVID-19 vaccine. I think that gets into a lot of ethics and how do you get to that? I mean, we have never mandated influenza vaccine. And one might argue that would be a first vaccine to mandate for schools because we know the big impact it's had. Now, is that going to happen? I just don't, we're not even mandating the COVID-19 vaccines in our hospital. Part of that's because we just want to keep, I do think, and we've seen this, that our vaccine uptake is getting stronger. And I think with these sorts of presentations, hopefully, open and honest communication, giving people the facts, that was the key for me, giving you the facts. We're going to have a lot of people vaccinated. And the more we do, the better we'll be. And I think that's the way we'll go about it at this point in time.
Jason, anything else on there that you see that you want to answer?
Yeah. So there's another one. Rate of infection after a vaccine. Well, I mean, I think Nicole, our rate of infection after a vaccine right now is basically what we know from the randomized controlled trials. Now that's important, knowing that, because we call it controls for a lot of things. That rate of infection, right, has been only about 4 or 5%. Now rate being whatever. I think when I've talked to some or heard from some of the experts in the community, we'll learn its impact on our rate of community infection probably when we get into March and April. Will we see a sustained low rate? And is that going to happen as we start moving it more? Now, as you all have read in the news, and many is like, one of the issues is, what is our vaccine supply? It's not clear. And, the states are receiving different orders that they didn't think they were, less amounts. Our counties are receiving less amounts. I think that's what's been the difficulty. So then I have asthma. However, people with asthma are on phase 1C with the vaccine, according to CDC website. Explain why. So what we've done is they said, look, that's this, if you are in one of these high risk groups for hospitalization, asthma being one, if you have, an immunocompromised, if you're over the age of 65, these higher risk groups that are leading to these enormous hospitalizations, right? That I can tell you right now, November was scary in the hospitals, right? Because we were seeing surges that were like, I'm not sure we're going to be able to handle all of these patients, which meant that if a healthy person maybe had a heart attack, which we can take care of fine, they might not have a place to be cared for because they didn't have the ICU because they were all filled up with COVID beds. I mean, that's some of these secondary impact. You look at what happened in LA. And so I think that's exactly why CDC, the advisory committee on immunization practices from the CDC said, look, we got to get the high risk people vaccinated, including those, especially those over age 65. There is no doubt the greatest risk for people is age, and that's over age 65. After we have been vaccinated, do we still need to wear masks? Joan, yes. For now, we do. We have a lot more to learn. So as much as I love that I've been vaccinated, I definitely still walk like I don't have the vaccine. Now, I have not been to a restaurant in 10 months. because I was too nervous. I did go to a restaurant for the first time because I was fully vaccinated. I felt comfortable to take my mask off for a little bit to eat, but then the mask went back on. Do you know if in the school studies looked at parent behaviors and transmission, like work from home versus in-person, et cetera, for those that did test positive? So I can tell you, Stacy, that our work is addressing that. We are basically looking at where is the transmission occurring, where are those risks, and as we've seen, a lot of the transmission that occurs is in households. I mean, the household is the place where we see it happening the most. Okay, how long do I think it will take to get everyone vaccinated this year? Wow, man, Donna. Okay, so don't hold me to this. I'm gonna couch this in two ways. I'm gonna answer the question: how long do I think it will take to get everyone offered a vaccine? How about that, right? Like, so that if my 14-year-old daughter can get the vaccine, like, when will I be able to offer her? I'm confident. I don't know how confident. I guess I'm confident above 50% that we will, by the fall. So let's say by September, everyone will be offered the vaccine. It might be even sooner. Some people are saying maybe July. That would be absolutely amazing. Now, vaccine distribution has to be there, but obviously I need the pediatric studies to be able to do that. Can I speak to concerns about long-term, the long haulers? Yeah, long hauler. Sorry, I got myself sidetracked. I can definitely speak to this. So what we have learned about the long hauler, can you speak to the concerns we hear about potential long-term side effects of vaccine, infertility? Okay, sorry, I was going to answer a different question. Well, I think what people have talked about this. There's been a lot of concerns about infertility in these pieces. I can say, look, there has not been the data from other vaccines where this has come up that we've seen that. Now, of course, like, that's, Crystal, why we talk about the fact that there's going to be continued monitoring of post the vaccines. The infertility stuff, again, brought up about a lot of vaccines, one of them be the HPV. I just think it's never been substantiated. We don't see that that's going to happen here in regards to that. So I feel very confident that's not going to happen, but I can understand where people are saying, well, I'm not sure I'm going to do that. But there's no data, not seen that at this point in time. As a staff member, I'm having to be right next to students to help them. So I'm not to be right next to students. Okay, Marion, so great question, right? So this is where I think, 2020 is a different time. You can be next to your students. It's just your time might be a little different. You might, they're in mask. I have work colleagues that I'm in my office right now. This is kind of my spot. I'll give you you'll get a view. Here's my office. It's a little messy right now, a lot of boxes, but you can see, we can get a little cramped in here. We have conversations. We get within 6 feet. I go within 6 feet of my colleagues. And I think it's different, right? You guys are going to be maybe a little bit more, but I think you can go in, have a minute or two conversation, help them a bit, move out, go to the next student, in and out. Now, remember, we love the Swiss cheese model, right? We have that Swiss cheese, right? And we have holes. And if we have the full block, you can't see a hole all the way through. So number one is the first step is we don't have people in here sick. And I talk about, like, we have to be kind of 200% accountable, 100% accountable for us, 100% for myself, 100% accountable for my colleagues. So that means if I have a student that has runny nose and cough that I've never seen before, and there's no excuse, and I'd be like, you probably should see the nurse, and that shouldn't be here. That's the sort of back and forth. And it's been successful. We've seen it happen. So hopefully that helps. Will Pattonville still continue to quarantine entire classes, or will we only quarantine 6 feet for more than 15 minutes? So Heather, the people that determine the quarantining rules within our county is our county health department. They have ultimate jurisdiction over the public health measures we put in place. So they have the packet, and at this point in time, that's where we are. I think what we're going to try to learn with kind of the project, this is why we're so excited to have CDC here with us to do this, is to learn about, well, if we're masked and we're in the class and we're doing well and our transmission is so low, do we really need to have the quarantining? And do we have this modifying quarantine? Is that a way? Is that a strategy that can kind of do that? But we, that's what we're working on. And I think it's important as we move through the rest of this school year and as we get into next fall, as we move through the rest of this pandemic. Okay, if you've had both of the shots, are you less likely to have problems with the variants? Yes, the data would suggest, or I should say the experts in the data in kind of this, what we call the test tube data, would suggest that we're going to be effective. The variants of that. Now, Joan, but this is exactly why I'm super excited about the project, because we're going to have positives. We're going to send them to the CDC. We're going to get to know if there's any variants here. We'll get to follow that in our own community. They'll be able to do some of the testing. But I mean, there's a couple of reasons why the virologists and the vaccinologists, those people that are experts in vaccines, are like, you know what, I'm not worried about the variants for two reasons. And these are biological reasons that hopefully I don't put too many people to sleep. Reason number one is this coronavirus is big in terms of viruses, meaning it has a lot of what we call RNA nucleosides there. So tons. The other thing is this virus, unlike other viruses, has a proofreader, meaning if it sees something goes wrong, it might try to repair it. Now, because it's happening so fast, it doesn't repair everything. So in order for there to be the variants that affect the shot, you'd have to have it change that spike protein, which is very big, enough that our antibodies wouldn't see it. And that's just not happened yet. And many people would say it's too big for that to happen. Now, this is what we're going to monitor, because maybe it's going to be like the flu shot where we have to get a new vaccine every year for the variants. And that's what we'll learn going forward. Okay, it's hard when you hear stuff and can't tell if it's rumor or truth. Oh, good. So it's helpful. Andrea, I agree. And that's what our partnership with you all, we want to do that, to continue that. Can you elaborate on the data about students at school getting the virus less than out of school? We are 100% virtual and strictly distancing. Are my students really more likely to get the virus by not being at school? Well, so Sarah, I mean, I think this is the question, right? I first see this data, I'm like, man, that's really interesting. I actually think that when we're 100% virtual, what we end up seeing is that for some individuals, they can't be by themselves. They end up being with their pod of people to do school, or they go with the group, or maybe they're at some other daycare or something else where they do school, where the strict enforcement or the culture, I hate to say strict enforcement, but I like to say the culture of the place isn't to the level that you find in the Pattonville school district or in the Kirkwood school district, and these school districts that have been so successful. And so I think that is why I think in the end, it's like, wow, being in school is actually helpful, because it keeps people from doing that. Now, obviously behaviors outside and when you're not doing that matters. And so I think that's why I think it can make some sense. Is a primary question in vaccine trials in children's safety, or does efficacy need to be determined? Monica, brilliant. It is primary safety. It's exactly right. And we actually do some dose finding as well, like not dose finding, but we use some of the doses that they had from adults, but we also do some different doses for kids, because we have learned that sometimes kids need more doses. And so that is exactly right. We do still look at kind of what your antibody levels are, because we know how much you need to be protective. So that's why it becomes more of a safety trial than as much an efficacy. We don't have to wait till we have so many infections in the kids and all those, but we will look at immune response, and we primarily look at safety. Okay, what happens if you're given a first dose of one vaccine, but the same kind is not available for when it's time for your second dose? Can you mix and match? Should you wait longer until the same time is available to you? Would there be enough supply second dose? So the United Kingdom has gone with the let's wait. They've said mix and match. The US, it says, look, we have studied it with the same. Let's not mix and match. So right now in the US, you're not going to mix and match. The way that they're rolling out the vaccine is to guarantee a second dose. That's how it's continued to be. I don't think we're going to see that. And they've also said, so for the Pfizer vaccine, it's a 3 weeks between first and second. Moderna is 4 weeks. And they recently said you could go out to 6 weeks. And, I think we're going to learn that the second dose can be longer. But again, I think they're doing things to make sure people are getting their 2 doses. There's 2 more I'll do, because I got to answer them all. Can you clarify the county quarantining policy? I thought it was just within 6 feet for more than 15 minutes. Should we quarantine an entire class or just the students within 6 feet? So for the most part, it is still 6 feet for 15 minutes, cumulative over 24 hours. There are some other subtle rules that are within the document from the county health department that I know school nurses have that does that. So sometimes you'll see whole classrooms based on some timing and other factors. But again, that's what the health department has. And they have a manual that school nurses have. Oh, Kelly. Okay, yes. People of color have been more severely impacted by the virus than the white population. What can Pattonville do as a district that celebrates our diversity to help mitigate the lethal impact to our Black and brown community members? Kelly, thank you for asking this question. For stating this. So the reason why, one of the major reasons why we went to Pattonville was because of your amazing diversity. That should be celebrated. And because of the things that you guys have done to make sure you celebrate that in your community was so important for us to be involved. We were not going to have work done where we were going to have 90% white population in a investigation of school transmission. That wasn't going to be right. I would say that it's important for everybody to know, right? It's not being Black or the biology of being Black or the biology of being Hispanic or the biology of being another ethnicity leads you to be more likely impacted. That's not it, right? There are systemic factors in our communities that have led to, for our people of color to be in situations where they are more communal. They're unable to have some of the things available. So I think as a community, we can celebrate our diversity, talk about upfront about the reasons why we have this impact to these communities, and then work with our communities to make sure that we address some of the distrust that is around the vaccine so that we provide you the facts about that. Because like we can talk about the history about why people would have that and why would there be a distrust for people like me as a white male who's in the most privileged group. Why, we need to do things to make sure you all in the Black and brown community and should get the vaccine and why you can have some trust in that. So I don't think that answers the question necessarily, but I want to celebrate the diversity with your community. I had the wonderful pleasure of picking up some specimens today and meeting some of the wonderful diversity there that just warms my heart and why I love driving McKelvey Road. And if anybody wants to write the song with me, I could use some help with the lyrics. Definitely the music, but so anyway. So with that, I think I got them all. Tim, to you, to your community, I can't thank you enough for this wonderful opportunity.
Dr. Newland, I know I just want to speak for everyone. Thank you very much. Look forward to the partnership with you over the next couple of months as well, and hopefully beyond that. To everyone that attended tonight, thank you very much. But I do want to remind you, don't log off just yet. You're going to get a survey here in about 1 minute. And after you answer the questions, please make sure you hit submit as well. And thank you again. Everybody have a great evening.
Thank you.